So without further ado, I would like to start the session right away. This is going to be for an hour, 25 minutes for both the doctor and the dietitian. So to begin with, I would like to invite Dr. Archana Nazre. Can we have her CV slide, please? Can we have the CV slide of Dr. Archana Nazre? Yes, so Dr. Archana Nazre is a very senior clinical dietitian with 25 years of experience. She has done PhD from Bangalore University. She is an IDLEC member and has also worked extensively in NutriBuzz editorial team, which was an initiative from IDA Bangalore chapter. She has worked as a clinical dietitian in Solis Healthcare, Shankara Hospital, NU Hospital, and BGS Global Hospital. She is currently working as a chief dietitian in Prashant Multi-Specialty Hospital. She has contributed several articles and publications in print media, has delivered many lectures to different corporate offices, and her media appearances has been in TV9 channel and Kasturi TV. She's also been a guide for many students who are doing MSc under IGNOU. It's a warm pleasure. It's our pleasure to welcome Dr. Archana Nazre. I invite her to take over the session to be a moderator for the sessions today. Welcome, Dr.
Thank you,
Archana.
Shalini. Thank you for the invite. Okay. Now, shall we start the session? Yeah.
Sure.
Thank you, Shalini. Again. Okay. Now today we are going to talk about necrotizing pancreatitis by two eminent speakers. One is Dr. Reddy and one is Prachi. Let me introduce Dr. Reddy first. Can I have the slide of Dr. Reddy, please? Dr. Reddy is an MBBS, MS, DNB resident from Surgical Gastroenterology Department in Sakra World Hospital. He's a dedicated and skilled surgical professional with an extensive experience assisting and managing complex GI, hepatopancreatic, biliary, and transplant surgeries. His clinical and surgical experience are upper GI, upper gastrointestinal surgery, pancreatiobiliary surgeries, liver transplant, pancreatic surgery, and intestinal colorectal surgeries. Okay, now I request Dr. Reddy to start the talk. So over to you. Thank you.
Thank you. Thank you for the invite. So good afternoon, everyone. This is Dr. Ramu from Surgical Gastro Department, Sakra World Hospital. So today we're going to present you a real case scenario where how and its importance of nutrition in the disease process. So through this through this presentation, I want to highlight the importance of nutrition in acute severe necrotizing pancreatitis. So coming to the intro, acute pancreatitis is the most common gastrointestinal disease for which patients are acutely hospitalized, and its incidence continues to be rising. Surprisingly, 80% of the cases will be a mild cases with a self-limiting disease, which resolve within a week of time. But however, in 20% of cases, the disease process will progress, and the patients may land up in severe acute pancreatitis in the form of persistent organ failure or necrotizing pancreatitis. So, interesting fact is, in a patient who had a mild acute pancreatitis, the overall mortality will be strikingly less than 1%. But a patient who had a severe pancreatitis, the mortality will be higher. So, it will in the range of 15 to 30%. So, after onset of pain or after onset of pancreatitis, 3 to 4 weeks after, the chance of pancreatitis becoming infected will increase. So if patient doesn't have any infection, we call it as a sterile necrosis. If patient had an infection, we call it as an infected necrosis. So in sterile necrosis, the mortality range is 10%, whereas in infected necrosis, the mortality will increase, and it is in the range of 25 to 40%. Coming to the pathophysiology, how a patient who had a pancreatitis will become infected and how it results in increasing mortality. So this is a brief slide on the pathophysiological mechanism, where the in the acute, it is not an only inflammatory disorder. Because of the inflammatory mediators and everything, there will be an endothelial injury, leaky capillaries, which result in a bacterial translocation from the gut, and the translocated bacteria will infect the pancreas, which are already damaged because of the inflammation, so resulting in an infected pancreatic necrosis. So coming to the real case scenario, here is a 52 years gentleman who is a known case of hypertension. He doesn't have with no prior history of any surgeries. He was diagnosed with a cholelithiasis and choledocholithiasis in an outside hospital. And for the same disease, he underwent a ERCP and CBD clearance with CBD stenting in the month of May in 2025. Post procedure, patient was developed a pain abdomen, and he was diagnosed with a post ERCP induced pancreatitis. Post ERCP induced pancreatitis, even though it is less common and less in incidence, accounting for around 5% of cases, but if the severity will be higher with the ERCP induced pancreatitis. So this patient had a post ERCP pancreatitis after the procedure, and he was admitted and managed conservatively twice for the same in a outside hospital. But he came to our hospital, the Sakra World Hospital, on 9th of May with a presentation of abdominal pain and intermittent moderate to high grade fever. After admission, we evaluated further, and we diagnosed him with acute severe necrotizing pancreatitis. His vitals at the time of presentation were: there is a tachycardia, there is a tachypnea requiring oxygen support, he's afebrile. So the tachycardia, tachypnea, and requirement of oxygen support, these all indicate a severe pancreatitis in the form of organ failure. So there is an effect on the pulmonary system. There is an effect on the because of the continuous fluid leakage and all those things. The patient have a heart load is increased. So there is a tachycardia also. And coming to the management of this patient, how we manage this patient. So initially, whatever the presentation of the pancreatitis, we have to give a time period of at least 3 weeks. We have to see the progress of the patient in this initial 3 weeks, how he is responding to the conservative management. If patient is responding to the conservative management and he is doing well, most times there won't be any need for any surgical intervention or any kind of interventional radiological intervention. But in case if patient symptoms are persisting and if they're not improving, then patient may need a intervention either in the form of radiological intervention or surgical intervention. So in all cases, like how we do, this patient was also managed initially with IV fluids, IV antibiotics, oxygen support, and other supportive measures. But he continued to have fever episodes. His tachycardia was persisting and tachypnea was not coming down. So thinking of severe pancreatitis, which is going to be a infected one out. So we have done a CECT, abdomen and pelvis, after which showed there is a huge amount of pancreatic, peripancreatic collections around the pancreas. Here you can see the collections around the pancreas, and this is in the axial section. You can see the previously placed CBD stenting for which he underwent for choledocholithiasis. And this is a coronal imaging. In this also you can see a lot amount of peripancreatic collections which are tracking around along the paracolic gutters. So after the CT, we confirmed that there are large collections were there in the pancreas and the peripancreatic regions. So because the symptoms were persisting, we have taken an IR opinion, interventional radiology opinion, and we placed the 2 drains for drainage of the collections. So after we place the drains for collection, patient was initially stabilized and the symptoms were mildly reduced. But again, the patient continued to have symptoms in the form of tachycardia and persistent fever episodes. So we counsel the family and the attender regarding a need for surgical intervention to remove the infected to remove the infected pancreas. So after counseling and adequate preparation, he underwent a ward procedure, which is basically video-assisted retroperitoneal debridement. So, and we have done the procedure. After that, we place the drains in the cavity where we have done the debridement. These drains will basically help us in the post-operative period through which we can give a continuous irrigation with a normal saline, so that whatever the infected material collecting in the cavity, it can come out through the drains. So the same thing we continued. We have continued the drain irrigation in the post-operative period for removal of the debris. To our surprise, on POD 8, patient was doing okay for 1 week, with his fever episodes were coming down, and he was able. So on POD 8, to our surprise, we noticed there is a change in nature of drain. So the usually the drain color should be either not bright red, or it should be like a mild blood tinge kind of thing, serous in nature. We will call it as a serous in nature. But that day we noticed a fecal material in the drain. So, and as a part of severe necrotizing pancreatitis, this is an expected complication, because the patient will have a necrotic material and which contains a pancreatic enzymes. So they will erode through the wall of the colon, and they caused a perforation. So that is why the patient had a fecal material in the drains. For the same, he was underwent a re-exploration of the ward wound along with lap-assisted primary repair of descending colon perforation with a diversion loop ileostomy. So basically, we have diverted the fecal passage, and we closed the site where the perforation has happened. This was done on the 2nd June. Patient was, this is his first admission during this. He was admitted on 9th, and he was discharged on 9th May and discharged on 9th June. So later he was clinically improved, but he was discharged with NJ tube in situ for the feeding purpose. Coming to his second admission details, patient was readmitted on 12th of June, 3 days after the initial first discharge, with the complaints of low mood, pessimistic thoughts, irritability, and poor sleep. We have taken an psychiatry opinion. We've started him on cognitive behavioral therapy. Antidepressant medications were started. His symptoms were significantly improved for the low mood and irritability. Again, in this admission, we have noted a change in nature of drain after 3 days of admission, for which we have done a CT plain abdomen with a contrast from the stoma, which showed us there is a pool of contrast in the descending colon area, which suggests the primary suture we have taken in the second procedure was given away, and he had the same complication again. So for which he underwent another procedure, like re-exploration of ward wound with laparotomy with primary closure of descending colon perforation, and along with necrosectomy. This is on 17th June. So, his total course in the hospital, he was hospitalized twice for his disease. First admission was around 31 days, which is from 9th May to 9th June. And second admission was for almost 28 days, which is from 12th June to 9th July. So, a total period of 59 days he was in hospital. And during his stay, he underwent multiple procedures, as I mentioned earlier. And all three of them were major procedures. His nutritional status in terms of key parameters like hemoglobin and albumin, when you compare from the time of admission, that is from 9th May to around the middle of the first admission, it was complete deterioration. He was in a downward trend. So the hemoglobin was from 10.5 to it came to 8.3, and later it went to 7.6 also. The albumin level, which was initially at 3.5, it came to 1.9, which is a key marker for nutrition. So on follow-up, the patient, after 2 admissions and on follow-up, we have removed the NG tube. Patient was tolerating oral diet, and whatever the drains were placed for the procedure, they were removed subsequently. Patient weight gain was present, and he is still in follow-up, and he is due for a stoma reversal. So in this case, we faced nutritionally, we faced many challenges, because initially we tried to give the oral feeds before the IR procedure, because there were many trials and many studies which indicate enteral nutrition is better in acute pancreatitis, because they will prevent the gut translocation and they'll prevent the infection of the necrotic collection, so which in turn result in the decreased mortality. So enteral nutrition is always preferred in case of acute pancreatitis if patient is tolerating. But because of his progress in the hospital and everything, so first before IR procedure we tried to give him oral diet, but he was not able to tolerate it. So we've given the nasojejunostomy feeds. We placed a tube across the stomach and into the jejunum. So across the jejunum, the advantage will be the pancreatic stimulation will be less. So the patient will be able to tolerate the feeds. So that we have done before the first surgery. And after the first surgery, we continued the NJ feeds because patient had continued nausea and vomiting. After the third procedure, the patient had developed a stomal diarrhea with an output of around 3 to 3.5 liters per day and feeds as content. And he also developed muscle wasting. Uh, and because his protein and calorie requirements are not meeting either in terms of oral or enteral nutrition, we started him on TPN just to maintain the calorie and protein requirement. Over a period of time, eventually the stomal diarrhea was settled. Patient was tolerating NJ feeds and discharged with NJ tube after the second admission also. So now I would like to invite Prachimam to discuss about the challenges we've faced in this case and how our nutrition department helped in managing this case. Thank you.
Good afternoon, Good afternoon, everyone. Now we'll be discussing how we manage that this patient nutritionally. It was a bit challenging task for us because we were not able to deal and meet the nutrient requirements as per the guidelines. So, as the few of the details we'll be discussing, what details we took from our side. So, the patient, as sir has told, was 52 years old male, and he belonged to a Hindu religion. He was working in IT company, and he was from a middle class. The main complaints were abdomen pain and the fever. Okay, and he doesn't had any major comorbidities except the blood pressure, and no food or drug allergies. And as a diet habit, he was a non-vegetarian, and his physical activities were almost normal. So when he got admitted, the major complaint was epigastric abdominal discomfort with distension, and he had fever for 3 days. Along with that, he had bilateral pedal edema, and his even the abdomen was distended. There was ascites present, mild to moderate level, and reduced air entry. And as sir has told earlier, he has gone ERCP, and his counts were high. And at the time of admission, and in blood culture, there was Klebsiella present. So the final diagnosis, as told by the doctor, was moderate to severe pancreatitis. So anthropometric data, what we collected was his height was 165 centimeter and weight was 59 kg, and the BMI was 21.2, that belongs to the normal category. As per NRS score, his score was 2, and he was nutritionally not at risk. And there was no recent weight loss or gain. He was having typical South Indian diet, and he was able to consume around 1200 calories and 50-gram protein with 15 gram of fiber uh, as a usual diet at home. And he was not consuming any form of alcohol, smoking, or tobacco, and even the outside food consumption was very rare. So these are the biochemical parameters, as we can see. So hemoglobin was on a lower side, his TLC was high, sodium was also little on a lower side, EGFR was good, creatinine urea levels were within the normal values, but only the albumin was on a little lower side, and these GGT levels were on a higher side. And in the USG, we found that he had grade 2 fatty liver, along with that gallbladder stones and moderate to mild ascites. His PT levels were high, DMR, D dimer was high, uh, the random blood sugar was 100, even the pulse rate, as told by the doctor, was high, and the saturation was normal. So we came to the conclusion that PA statement was that inadequate intake due to chronic medical condition that is leading to malabsorption, as evident by his reduced oral intake. So how we calculated energies and protein for him was as per using ideal body weight, because he had ascites also. So these are the calculations, and these are the medications that were giving to him during the hospital stay. So there was no major food and drug interaction. So we will just run through a course of his admission, so what all happened and how we tried to dealt with this case. So when he got admitted that day, the patient was on NPO. Later next day, he started on a full liquid diet at 60 to 80 ml per hour as tolerated, and we have started adding the ONS also, because we knew that the pancreatitis in the pancreatitis, catabolism will be on a high side and he will be losing weight. So in the liquid, he was around, along with the ONS, he was receiving around 660 calorie and around 25 gram of protein. He tolerated the oral liquid diet. His bowel also opened. He didn't had any abdomen pain or fever or nausea. So second day, the doctor started him on a soft diet, obviously as tolerated, and we wanted him to give a high protein diet. But his abdominal girth was 107 centimeter, and he had mild distension, but bowel was opening, and the fever was also there along with the tachycardia. So next day, he was NPO for the CT scan, and these are the results shown in that, and it also proved that there is a pancreatitis. So after that, we have inserted NJ tube for him, and because he was not able to consume orally and he was complaining of air hunger syndrome, means he was thinking that he's not able to breathe, and he can't breathe, he can't eat also. So he was in that dilemma that I can't breathe, so I can't eat. So that was leading to a poor intake. Along with that, even he had continuous fever spikes and tachycardia. Later he was we have added semi elemental ONS also. uh, Mm, and then less after that, when he was
Code blue,
tolerating
upper
the feeds,
basement, engineering
uh,
department, all clear. Code blue, upper basement, engineering department, all clear.
so we were
Code
able to
blue,
meet around
upper basement,
1400 calories
engineering
and
department,
59 gram
all
of
clear.
protein. But later he, in spite of giving the semi-elemental ONS in his feeds, he had episodes of vomiting and loose stools. So we were told to review for the loose stools, because generally we don't expect loose stools when a patient is on semi-elemental diet. But what we came to the conclusion is that he was not tolerating the semi elemental supplement. So we stopped that semi elemental supplement, and we thought of giving a try. Maybe he's allergic or get not able to tolerate any of the compound in the supplement. So we started giving him a normal high calorie, high protein supplement, which was mainly whey isolate. So it lacked the lactose content. So we thought it could help. We have added even the curd in the feeds. So we were able to provide him around 1300 calories and around 80 gram of protein, but still the loose stools didn't come down. They were there persistent, so around 4 to 5 episodes were there. So later we thought of adding eggs, because his albumin was going down. So egg was added to his feed in a form of a supplement only. We thought maybe the whey protein supplement also, or if, because he didn't had any allergy, so we were confused why he's not able to tolerate either the normal supplement or the semi elemental. He persistently had loose stools. We have taken all the measures. So later we replaced these feeds, few of the feeds with egg-based blends, but we were not able to get much amount of energy and protein out of it. Later, doctor analyzed that he had complications, and he was, as told by the doctor, he was shifted for a ward procedure. So after the ward procedure also, he was not able, like we started with the NJ feeds along with the ONS, and we thought of giving oral clear liquids thinking that his intake and all will improve. So we started with 30 ml of oral liquids along with the NJ feeds at 150 ml per hour, but still there was no change, and he presently had 10 to 15 episodes of loose stool, even the vomiting. We thought maybe the supplements are the culprit, so even we switched to total kitchen feeds also, but still there was not much improvement, and we were not able to meet our obviously calorie and protein requirements. But we didn't stop giving him oral, so we whatever amount he was okay taking orally, that was allowed to him, and preferably like he was preferring to have more of the clear liquids. In between, later what happened is intermittent hiccups started along with the vomiting. So again he was kept NPO. So once we kept in NPO, that time we observed that the consistency of the stools improved, and even the frequency also decreased. On post of day 8, again he started with 4 to 5 episodes of loose stool, along with the along the NG feeds were ongoing. We didn't stop that. Later uh, again we found out that there could be some internal issue, that is why the loose stools are not stopping. So then later doctors planned to go for a surgery for him again, but before that, again we to confirm that we have started giving him colored feed. So if there is anything that is leaking out, we will be able to see it in the drains that were placed earlier. Later, after the re-exploration, the NG feeds were continued along with the oral liquids. So there was no foundation. Whatever amount of oral liquids he was able to tolerate, we told him to consume. The stoma was healthy, and the stools were semi-solid after the ward procedure, and even he was tolerating the NJ feeds with the added high-calorie, high-protein supplement. We have tried earlier that the semi-elemental feed, whenever he was getting, he was having a pain and the loose stool frequency increased. So that is the reason we continued with the normal supplement. On post-op day 3 also, his stoma was functional, but there was little bilious output. But the diet-wise, we didn't change anything, and the same thing was continued. Post-op day 4, the liquid stools were there, and later oral intake deteriorated, but the amount of stool remained same. So once we are whatever supplement we are giving till now, even he was not able to tolerate that, and he complained of getting a colic pain. But later again we changed the supplement. We just changed the brand. Maybe the brand wise we thought he's not able to tolerate, because the composition was almost same. So we told him to try in a smaller and lesser quantity, and the NJ feeds, and orally whatever he is able to have, he can take. And he got discharged for that admission. So what happened again, after 2 days he got readmitted, and because the major reason this time was suicidal attack. He thought he is not able to cope up with the disease condition, because till now he already had a long stay of almost a month in the hospital, and with so much of loose motions, he is not able to take orally liquids he was disliking, and he wanted to eat, but because of the loose stool and the abdomen pain, he got so frustrated that he said, I don't want to live, I want to die. So for that reason also, we thought like doctors thought that we will readmit him, and see what is happening, why the loose stools are still persistent even at home also. So the this time admission, the major concern was stomal diarrhea and depression, and the fever. So later doctors found out that he had little hernia also, so they thought of operating on that and re-exploring about the like the ward procedure that they have done re-exploration for that also. So again he was kept NP on that for that. The next day again we started on the feed with the ONS and the kitchen blends. Here we have written 150 ml, but the next feed immediately we didn't give 150 ml. We gradually stepped it up. We have added little coconut oil to give fats as a MCT, and but still his target was very high, around 2000 plus calories, and we were not able to meet more than the 1200 calories. Even his hemoglobin dropped and he had infections also. So the albumin level was dropping out, his edema increased, his distension and ascites increased, and it was very difficult for him to consume anything orally. So that is the reason his oral intake remained poor. And again he started with the hiccups. And on his request, because he was on the tube feed since last admission, so it was almost a month, doctors removed NJ, and he promised that he will be he said that he is not able to consume orally because of the tube. Psychologically he thought that the tube is interrupting his oral intake. So we thought, okay, give a try to it. And then in consultation with the doctor, we removed the NJ tube, but it didn't gave us any benefit. His intake remained poor. He was not consuming either the solids or the liquids in the appropriate quantity. So again NJ was reinserted, because in the last 2 days his oral intake was only 300 calories and around 30 gram of protein. So it was very much low, so what we expected. And he was not willing to consume even ONS orally. So that is the reason we were not able to reach the targets, and we were very far off from it. So later again, initially NG was inserted, but again he had vomiting and he felt colic pain again, and he thought that once he is getting the feeds, he's sweating more. So later that NG was turned into FJ. Then again we increased the amount to 150 mls gradually. Still we were not able to meet more than 1300 to 1300 calories, and around protein we were able to meet because we were adding more of the high protein supplement. He had this psychological issue that the regular supplement is giving him pain. So there was one specific brand, he was okay with that only, and he insisted us that to add that brand only. So that is the reason we were able to increase the protein, but not to meet the we were not able to meet the calories in spite of adding oil and giving only the supplemental or the EN feeds. So later he was able to tolerate the feeds. We even added BCA for him to have orally, so that his taste, he will get more of the amino acids and his taste also will improve. And later what we observed is whatever feeds we were giving to him, they were coming out in the stoma. The way exactly feed was given, same way it was coming out in the stoma, and he was having lot of abdomen pain. So again we thought, like initially it was bile, but later along with the bile, the feeds also came out exactly how we gave within half an hour. So it was difficult for us to manage that way, because whatever we are giving, if it is coming out in the stoma, and he was not able to absorb anything. Later again, the along with the bile and the feeds, the stool, or the stool content, little amount of stools also started coming in the stoma bag. He had again vomiting episodes, and he was not willing to have orally also. So whatever little amount of NJ we were able to give, it was just able we were able to provide only 900 calories and around 29 gram of protein, whereas you can see his requirements increased, but we were not able to meet. So later, to avoid refeeding and further malabsorption, because he already has NSRK, his albumin levels have gone down, lot of muscle wasting we have observed. So then and he was not willing to start on the semi elemental so that tolerability will be better. And because of the abdomen pain and vomiting, we started TPN for him. In between, the doctors have done OGD also for him to find out if is there anything, because randomly he were having episodes of vomiting, sometime bilious, sometime nothing was coming, he was just having nausea, but psychologically he was getting so much depressed that I'm not able to eat, I'm not able to digest, and everything whatever he could observe that whatever he was consuming was coming out. So even I have attached the stoma bag photos also, you can see what how was the output na. So it was difficult for us to manage him, but we continued the feeds in the same way. And once he was not tolerating, then we planned to start on the TPN, because earlier even we thought of starting TPN, but he himself was not willing and was not agreeing to start, in spite of we counseling him so much that you are not able to take orally, the enteral feeds that we are giving are not getting digested, you are having too much of loose stool. But he was denying to start TPN initially. So we started TPN very late. We counseled him so much that this gut dysbiosis will happen, and TPN will not cause infection. It will give you strength. With so much counseling, see how much you have deteriorated since last 2 months. With great difficulty, he agreed to give a trial to the TPN. So we started TPN for him at the rate 60 ml per hour, and we gave only the carbohydrate and the amino acid component to it. To fat part we omitted along with the NJ feeds, and we told him orally also you can have whatever is possible, we will give and through NJ also, but TPN should be there to supplement whatever is missing in your diet. So later he agreed to give TPN only for few days. Again he had issues continuing the TPN. um, so after 4 days, we were forced to stop the TPN on his request, and in between you can see the fever episodes are still there. His intake didn't improve much during the hospital. Say there was always a deficit of calories and proteins, we were not able to reach the target, but psychologically he improved. After so much counseling for 2 months, we were able to counsel him, so he agreed that once if we are discharging him, he will be improving his diet. So we took a risk and he got discharged. We gave him a proper diet plan of how many calories to come through NJ, how many calories he should consume through oral diet, and then he came for the follow up, and we could see the improvement in his weight, and his even the MUAC improved. So it was a difficult case for us to challenging case for us to, but still till the time he was in the hospital we were not able to meet his nutritional requirements. Later once he went home and he came for the follow up, his diet gradually improved, and now he's still continuing on a high protein supplement, and he is able to meet his target of calories and proteins like within 1.5 to 2 weeks post discharge. So this is how tried to manage him nutritionally. The vitamins and the minerals all were added in the TPNs in the IV, but still whatever is missing in the diet uh, could not be substituted during the stay. So thank you.
Thank you, Prachi.
Yes, ma'am.
Thank you, Prachi, and thank you, doctor. It was really a good case presentation. Such a complicated case it was. I'm sure both of you have taken a lot of efforts to bring the patient back to this
Yes,
thing.
ma'am. We were not able to analyze what to
I
give,
know.
what not to give. He didn't had any allergies. Just after
Yeah,
giving the feed, he used to complain every time, not tolerating pain, sweating.
I can see that every day how much you have struggled to both physically and psychologically.
Yes, ma'am.
It was really a challenging. It was very nice presentation from both of you. Thank you so much. I thank you for. Let us take some questions from now on.
Yes, ma'am.
Aisha, can you share the questions? There are not many questions, I guess. But it was really a good Prachi. Both Dr. Reddy and Prachi, it was really good, this thing. And it was honest feedback saying you did not meet the requirements. It happens. It's very difficult to meet the requirements, especially in such cases, 1,400 and 101 grams you have met itself is a big,
We were not
you know,
able to reach 50%, ma'am, so that was
yeah.
challenging for us.
It was really good, this thing. Okay. I thank you both on behalf of IDA for coming and participating here and sharing a very good questions. Let me check if there is any
Yes.
questions there. Shalini, do you have to ask anything?
Yes, but I'm not audible. Am I
Yeah,
audible
yeah.
now?
Yeah.
Hi.
Yes.
You're
Thank
right.
you. Thank you, Prachi and Dr. Reddy, for such a wonderful presentation. It's so many ups and downs. I think it was a roller
Ah,
coaster for everybody, the patient and the care team. So, a beautiful case. Dr. Reddy, a few questions. If you, not particular to this patient per se, but have you come across patients with pancreatitis who are going up to type 3C, type C of diabetes? Have you seen in your career any such patients due to pancreatitis ending up with diabetes, type C diabetes? Um, Dr. Reddy is there? Prachi, if Dr. Reddy is there?
Yes, he's there. I think some issue in connectivity.
Okay. Okay. No problem. Meanwhile, Prachi, if was there any need of any crayons, enzymes for this patient?
That were all given, but they didn't help much.
Oh, okay. Okay.
Hmm.
Right. And through RT-feed only it was given?
Yeah,
NJ
yeah.
tube or RT-feed only?
They asked question.
See, Dr.
Shalini, doctor is telling that somebody should add him.
Yes,
She's not.
yes, yes. I shall be helping. Yeah. Dr. Reddy, thank you so much. I think you were not there.
Yeah.
Thank you so much for the presentation. It was really a good, complicated case which was handled so well by your team. So my
Right.
question is, have you seen cases where patient ending up with type C or type 3 diabetes because of pancreatitis? Probably not with this person, with this patient, but have you come across?
So they need a very long follow-up, whether the patient had developed diabetes or not. To say they need a very long follow-up. Like my experience in here in Sakra, I have not seen such cases. But the patients who were operated like in the earlier years in 2006, 2017, 15, when they came for follow-up to visit us, yes, there is a few patients have diabetes.
All right. And also here in this patient, he developed a complication of fistula because of the enzymes acting on the pancreas and the surrounding organs. What other complication when we can see because of the active enzymes from the pancreatitis?
So
Uh,
most likely, the pancreatic enzymes can erode through any part of the body, any kind of tissue, because they are rich in like carbo. They will have enzymes which can digest the carbohydrates, proteins, and fat content. So basically, it's more of collections. And if there is any adjacent organ like small bowel or anything, if the infection is so severe, if the enzyme load in that area is more, they can erode through the walls. Yeah, there will be pseudo aneurysms, there will be like bleeding chances also will be there. Nearby arteries like splenic artery, if there is any involvement of those arteries, the patient might have a splenic pseudo aneurysms. because the vessel wall will have three layers. If the elastase enzyme will be there in the pancreatic enzymes, so if that elastase enzyme erode the vessel wall, there may be weakening of the vessels, so they will develop pseudoaneurysms, and over a period of time they might rupture also, leading to bleeding and all those things, which is like a more severe complication of pancreatitis.
Right. So here also after the first admission, no, I think when he developed the fistula, it was in the first admission, right?
It was in the first admission only.
Yeah, yeah. And he went home and again he came back. By that time, the suture had got dissolved again because of the enzymes only. Is that what would have happened?
Uh, Difficult to say. Was it because of the enzymes or because of the surgical technique? I will rather say because the disease process is still going on at that time, and the suture might not have taken up completely. I'll say from my perspective, it will be a surgical technique only, because if the disease process is there and if it is so severe, sometimes even if you take knots or some sutures, they will not hold properly.
All right, all right. And I had asked this to Prachi. Was there the you seem to have given the crayons also for this patient? The crayons enzymes was given to this patient. Was it given for this patient?
No, we didn't give
Yes.
Creon to this patient.
Yes, okay. But also, if we have to give for the patient, what is the protocol? If anybody of you can answer, if you can throw some light on how many crayons, because the guidelines say around 500 units per kg per meal. But since it comes in a capsule, and if you have to give it an RT feed, what is the call that you take? How do you decide? How do you divide and give? Would you want to answer on that?
So the crayons are basically the pancreatic enzyme supplements. So
Right.
these are essential mostly in patients whose exocrine and endocrine function of pancreas is completely off. Like in patients who are like chronic pancreatitis, not in acute pancreatitis, but patient who had a chronic pancreatitis, in whom the exocrine activity and endocrine activity was completely switched off. They will not be able to produce the pancreatic enzymes which are necessary for the digestion process. So usually they will manifest because the enzymes were not there. They will manifest with fatty stools and very foul smelling stools. So in those
Okay.
patients, pancreatic enzyme supplements were advised. I'm not sure about the dosing. I'm not very sure about the dosage.
No, no problem. No problem.
Yeah.
Sure. Do we have any other question from anyone? Audience?
Questions. There are no questions from audience as of now, Shalini.
Sure.
Okay. I thank both of you, Dr. Reddy and Prachi, for coming over to this session and presenting such a beautiful case. I'm sure it's a learning experience for people who have joined here. I'm sure they'll be able to implement all these things, whatever you have shared in their daily practices. Thank you so much for coming here. And thank you, Shalini. Thank you, Sandhya, everybody for this session. Okay.
Yeah.
Thank you.
Thank you,
everybody.
Ayesh.
Thank you.